And then welcome to this week's Biomechanics Q&A. So the idea is that I record these so that they are all over on the YouTube channel for anyone who has just found them. We've been doing these free live Q&As every Wednesday during the lockdown period. So you can ask any question you like around biomechanics, movement, exercise in the human body, and I will endeavour to try and bring you answers or ways to find the answer. If I don't know the answer, which can often happen, then I'll hold my hands up and I'll say I have to ask a colleague. So feel free to ask at any time. So Zoom guys, you can tap away into the chat box if you've got any questions. Instagram, how you doing? Hi, Elian. Just stick a question in if you've got one, but I have got 3 for today. And a bit of water, and I've got my mascot. My dog, always Broxy, always has to sit where my feet are. So at the moment, I'm standing in like a star shape with a dog between my feet. So how are we doing? Everybody okay? So this Q&A, I've got 3 questions from the lovely Marina again. Now Marina has, she helped us out with questions last week. And what I say about Marina's questions is she asks really great questions. So very often, if you have a skill in asking a question, it can help you find the answer much quicker or relatively easily. I get asked a huge amount of ambiguous questions, more particularly about specific issues, but it's a generic question. So, for example, people can ask me about their problem, and if you ask me online about your problem, I cannot be prescriptive or specific or diagnosed. I can't do any of that online, so I have to generalise the questions, which is what we did with Jackie's hip question last week. So what I can do is just sort of impart some information about how you can find the solution to your specific problem. I can't give a diagnosis over line. I'd have to go through a full history. I'd need to understand medical conditions. So it becomes very personal, and there's obviously data protection, all of that. I'm sure people don't want to share everything. So I do have a system set up that allows me to do those kind of consultations through lockdown online with my colleagues who are physios and osteopaths. And collectively, what we do as a group, we've got a safety net online consultation form, which takes you through 5 sections. And they're effectively red, amber, and green. Red being A&E, mate. Amber being, let's ask some more questions, let's explore, this could be a clinical issue, we might be able to refer you. And then green is, we can go ahead with exercise and movement-based processes. So if anybody out there does seek attention, they do want some help, there's no cost to the initial analysis, but then the costs kick in depending on where we send you off to, or we can just send you back to your physio, your GP, if that's the case. So it's a really great system and has been extremely useful over lockdown. We've always had it in place, we're just developing it now based on the current situation. So there's a couple of resources for you there. Go to the YouTube channel, Biomechanics Education for all the old ones of these, and then the safety net system we've got online. So Charlie Mo, okay, there you go. There's a generic question. So my question back to you, Charlie. So let me just pose the question for those over on Instagram. I'd love to hear what you know about the tibialis posterior. So it's a very broad question. It's a muscle. It works in the lower leg. What do you want to know? So my question back is always, why do you want to know? More often than not, if you give me the reason why you want to know, that's where we start to explore, okay, now let's get into something interesting. So I'll go back to Charlie and ask him to expand on that. Yeah, no problem, Leah. Leah's having a lunch, that's fine. Just have a quick look over on Instagram, see if any questions are coming in. Hey, Tom. And Facebook, I can't see you guys, I'm afraid, so I'll have to come back to you guys after the session. So I've got some book recommendations for later on. I thought that might be interesting, but we're going to go for about an hour. And so what I'm going to hope to do during the hour is help Marina with her 3 questions. As I said, they're really, really good ones. Charlie's obviously adding in So in response to his original question, what do I know about tibialis posterior? He's adding, mine is playing up, soreness and weakness has been persisting for some time. However, I knew you wouldn't be trying to solve my, yeah, of course. So then my question back to you, Charlie, is how do you know it's tibialis posterior? I'll let you respond to that whilst I come to this first point. Now, I guess the emphasis of today with these 3 questions is I want to share with you, when I'm asked a question and I'm thinking about my response, what's the system I go through? So some of the information I may already have from previous learning, but how to research and understand resource quality so that you can do it yourself. You don't need to come to me. I love that you come to me. I think that's great. But obviously, I'm not always there. This is just an hour a week during lockdown. But so that you start to feel more confident about finding information out yourselves. So I really want to use Marina's questions to help me help you understand. I'll just share with you how I do it. So what do I do? First most common resource is obviously the internet. So we type away maybe the question, and I'm sure what Charlie would experience if he typed in, I'd love to hear what you know about tibialis anterior, or if he asked Siri, it would be a very generic response. It's a muscle, it goes from here to here, it's responsible for this. So you need to then elaborate to help get the internet to help you start to explore more detail about what you're trying to find out. So that's a good way of thinking about your questions, is how would I find out on the internet? So that would be a go-to resource. Obviously books are fantastic resources as well. And this is one I gave, I think it was last week. And I think there was about a dozen people went out and bought it. I don't have shares in this company. I wish I did. So just to highlight, my favourite anatomy book of 3 decades of being in the industry is still this one. It's pretty knackered now. I've actually got about 5 editions, so that then when I'm teaching, I can hand them out. People can borrow them as well. Still my go-to resource, written by Andrew Beale. I think he's on the 5th edition. This is the 4th. And I did previously get a DVD with it. I don't think it has the DVD with it any longer. But a fantastic resource if you're learning about anatomy. Now, it's written for manual therapists, so it talks about how to palpate. But I like that method, even for personal trainers or people who are not so hands-on, for learning about the body, because we're quite kinesthetic. So if you have a skelly or a willing participant who doesn't mind you prodding and poking their bony prominences, it's a great way to learn about the body. And so that would be another recommend. So the internet and books are great resources. But we need to be careful about the internet as a resource, because Wikipedia is kind of renowned as, you could go in and set something up on Wikipedia, so understanding the resource is really key. So I would always go to several resources. I would want them to be good resources like a PubMed or a medical journal, which usually they just give you partial information and you have to subscribe, or you have to know someone who is a clinician or a student of medical practice, and they can often get access to full research papers, because the researchers need to reclaim some royalties back. So with respect to those guys, some papers will cost you money. Sometimes you can get some nice little nuggets of information by looking at sort of those kind of resources. So we'll go into the first question. Now, the first question that Marina asked, and she has started some of our online learning. She's now invested into our Biomechanics Coach Diploma, and there are 3 sections to it with 5 modules. So she's now started to research and read around the first module, which is around the pelvis and spine biomechanics. She's done the online classrooms, or she's in the middle of those. She's heard some of the language that we've been using in the classroom. She's coming back and saying, what do you mean by that exactly? So really good questions. The first one she's asked is, can you explain what tethering means? Now, for those who, just to put that into context in the way Marina has heard that language, we talk about when, as a movement professional, working with a client, we want to test and exercise the nervous system as a substructure. So we talk about the 3 subsystems, and I'm going to give you an example of that in relation to a second question. So the muscles, the bones, and the nerves, and the muscles includes the fascial system as well, if you like, the soft tissues. When it comes to the nervous system, it's usually an area that, as movement professionals, we don't feel as confident about. It's usually, oh no, that's not an area that we generally study in great detail. It's always thought of as a problem area. Sciatica, carpal tunnel, neural type medical conditions. We leave that to the clinicians. However, what we can do if we better understand the nervous system and the way it functions is we can reduce the risk of a client getting sciatica or carpal tunnel or tennis elbow, those kind of repetitive strain injuries that affect the nervous system and make it more sensitive. So when we talked in that lecture for the Marines watched about the nerve tethering, we're trying to differentiate between an impingement and a biomechanical issue. And a biomechanical issue can become an impingement or can become a medical issue. But in terms of understanding our remit, where it sits, how we differentiate, if somebody comes to you and they've been diagnosed with an impingement, that is now becoming a bit more of a medical issue. That's kind of not really our remit, unless we have all the systems in place to clear the client, a letter from the clinician, guidance on what we can and can't do to work with a client who is experiencing or has been diagnosed with impingement. So that's not what we're looking at when we're looking at the nerves when they're problematic biomechanically. What we're looking at is when the nerve is tight or tethered, and that's a pre-state to it becoming something more problematic like sciatica or carpal tunnel. So Marine is trying to understand, what does tethering mean in terms of the difference? And so if you go onto the internet, which is what I did just to sort of go along with that, tethering is what you might expect it to mean. It's fastening or tied down. And interestingly, the example given on the internet is a bundle of nerves that connects the brain and the body. So that's how we're using it here. But where we're understanding tethering is it's adhered or stuck, and again, it depends on where you might use this language, on how you might refine it. So with a client, it's just tethered, it's a little bit sticky, we're going to try and get it moving again. Whereas with a clinician or a practitioner, we might talk more about the fascial connections. We might talk a bit more technically. So depending on where you are using the vocabulary might depend on how you use the language. But just to you guys as professionals, how I would define it to you is, if you imagine within your body the way the three subsystems interact, so the myofascial, the neural, and the skeletal, they're all interconnected. So if you imagine, for example, an adaptive muscle like piriformis. So piriformis is in the hips. It's an infamous muscle in terms of, we often have heard of this one. This is one of the pieces of anatomy we all generally remember. And it goes from the front of the sacrum across to the greater trochanter of the femur. It is an abductor, an external rotator, it's a stabilizer when the foot hits the floor, hopefully, and it will also internally rotate if the hip is flexed above 90. So it's quite a busy muscle, it's quite deep, which is why it's often quite problematic, and it is also renowned for having a very close relationship with the sciatic nerve. Now, the nervous system is one continuum through the body. Starts in the brain, spinal cord, and the peripheral nerves through the arm. So they are all connected, they're all one structure, and we name them to understand which part of it we're talking about. So the sciatic nerve is the part of the nervous system that has a close relationship with the muscle piriformis. And if you look at cadaver variations, the sciatic nerve may go under piriformis, over it, through the middle of it, around it, and then there's maybe 6 or 8 orientations that I've heard of that relationship anatomically. And this is where anatomy gets really frustrating, but really exciting, is the books tell us so much, and then as you study more and more, you realise all these differences we see on the outside of each other there's differences on the inside as well. So when we think about the nerve tethering, what we're suggesting here is it's quite a nice way of understanding the relationship between the muscle, the fascial link, and then the nervous system. So if you imagine the nerve and the muscle, and then all those, they're connected together, the kind of fascial connections between them. And if you imagine that the muscle has got tight, overactive, has adapted because we sit on it a lot or we don't use it enough, it could affect the movement or capacity of the nerve through that connection. So it could happen the other way around. The nerve may get tight for whatever reason, and it could make the nerve go into a different state, trying to protect the nerve. So there's this whole kind of chicken and egg thing where we have no idea which one kicked in first. The only way we can find out is by assessment and corrective techniques, and then see what happens. And the technique that works is likely one of the solutions. So the tethering I'm talking about is one of these. It's where the muscle and the nerve connection has kind of got adhered, a little bit sticky, and we may be totally unaware of this, except for either loss of range, loss of function, or maybe none of these. We may feel like we move really well, but a movement assessment might pick it up as a potential problem. So for example, we could do a nerve test. I test the range of the nerve, or we could do a pelvis function test and test the range or movement capacity of the muscles. Or what would make more sense would be to do, you guessed it, we do both. So we test the pelvis, we test the nerves, we test the joints and all the subsystems, and we identify which ones of those for each part of the body, and in this case the pelvis, doesn't have symmetry or full range, or there's just a sensation kicking in before a certain range that we feel the nervous system should have, for example, to identify if maybe the nerve is tethered or adhered. And then the solution to that can be we release the muscle, we mobilize the nerve, and or we release the joint or mobilize the joint. So I'm hoping, Marina, I'm not sure where she's logging in. If you're on Facebook, Marina, I'll check in there in a moment. I've got 3 screens going on. So hopefully that helps answer the question of, can you explain what tethering means? I think ultimately the most important thing is it's where the nerve is adhered. It's not a major issue, it's not a clinical issue at this point. It's just maybe lost some of its range, and it may be causing either the muscles to appear tight or problematic, or maybe some kind of sensation of tightness, or we lose a little bit of range when we touch our toes, or we do an SLR test, which would be a test for the nerves, or even the force sign on the pelvis. If that brings up any further questions, please do feel free to type them in. I'm just having a quick look over on Instagram. Hi there, guys. Good to have you all along. Oh, there's loads. You got nothing better to do? Come on. There's a question in there from Paul. How to get full range extension in patients with SI joint pain? My apologies, I cannot answer that question. It's too, it should be a specific question. Pain is very subjective. So I'm sorry, Kamal. There's no single answer. I would need to understand the full case history, and that would take a couple of hours. So my apologies. There are so many things that can cause sacroiliac joint pain that we did do loads of tests to really identify it. So my apologies, I can't answer it. Professionally, it would be inappropriate to answer it. The only thing I can do is offer potential causes, and I don't want to give the false impression that I'm suggesting that anything I say could be this, it could be, but I don't want you to think I'm giving you a diagnosis, because I can't do that in a 1 hour generic sort of Q&A post. So my apologies. Do private message me if you wish, if you want to go into any detail or go through the safety net. You're welcome. So hopefully that was helpful. So just coming back to Charlie Mo's question, been reading around by figuring out the origin, insertion, and the symptoms matching. Okay, so Charlie's original question was to understand tibialis posterior. I asked him to elaborate further, and so he's experiencing soreness and weakness. Now I'm assuming the research that you've done, Charlie, is around movements that relate to the movement that tibialis posterior is responsible for. Yeah, one of the problems with that, other muscles will also contribute to those movements. The other problem with that is it's not taken into account potentially the nervous system, which also passes down the back of the calf or through the lower leg. So again, it's still very generic. So I'd want to explore even further because what you're doing here is the same as Kamal has just asked over on Instagram, is it's kind of, you're relating it to a personal symptom that you have, and there's too many things that could contribute to that. Your research is interesting, it's valid, it's what we all do, you do a bit of research. I know also about ACL constructions because I actually chose not to have it in the end, maybe because of my research. So you get a bit nerdy about it because you're experiencing the symptoms, you're trying to work it out, you're trying to self-diagnose. Makes sense, and everything you're doing and coming up with would make sense. What I'm throwing into the mix is there are other things that could be contributing to your soreness and your weakness rather than making the assumption it's tibialis posterior. That may be one of the contributors, but actually this conversation might be good for another Q&A. It's just spinning off some thoughts that I'm having about how to take that in terms of how we find a solution. And that's down to movement analysis. So a really popular biomechanics Q&A I did some time back last year was we went through how to analyse movement and how to understand what that means and how that relates to the anatomy, which might help, Charlie, with your question about tibialis posterior. Would that be okay with you, that maybe we spin that into, maybe next week, we'll do that one. We'll have another chat, and if you're happy for us to do the chat, or as much as you want to share, live in a Q&A, and we'll run through movement analysis. And what I'll do is I'll get you guys who are in here to interact and let me know what you think, and we'll have a play around with movement analysis. I'll show you how I try and teach it to really simplify it. So can we do that next week? The next week, movement analysis. So same time, same place. Nice one. Good, some content. Thanks, Charlie. So question 2, so this is where Marina asked me, can you explain, now this is Marina's language, and so I'll try and define what I think she means by it in a moment. So can you explain how the pelvic gait works, as in one knee flexes, something happens to the pelvis? So what I think you mean, Marina, is what happens at the pelvis during gait. I actually quite like that term, pelvic gait. And it may be a term, but I've just never heard of it. So what I'm going to do is I'm going to go through the visual representation of what I think Marina is asking about when we're talking about the gait cycle and what happens at the pelvis and the way it moves and how that affects the structures. This will all also help me to talk again about what I've just talked about, the pelvis with piriformis and the sciatic nerve. It may also help Charlie with your question, so it'll help me sort of tie it all together a little bit. So I'm just going to stand back. Let me just move the cameras, do that. Just make sure, oops, sorry, Instagram. Let me get you back. Oops, there we go. Let's get you over there. And, okay, you're in. My apologies. Okay. Okay. So on the video, what I was doing was trying to explain how when we walk, when we move, what happens as a compensation if something's going wrong, for example. So we talked about the movements at the pelvis, and to make this nice and simple, we talked about anterior and posterior tilt. So the whole pelvis will move in a forwards tipping motion, which is anterior tilt, and a backwards tipping motion is a posterior tilt. And those are, sorry, let me bring you back Instagram. So make sure you can see, there you go. When the pelvis, the way the pelvis moves during the gait cycle is that happens independently from one side to the other, hopefully. So then you get this rotating action, and it happens around the joints in here, which is your sacroiliac joint, which is where the two bones of the sacrum and the ilium come together and meet. Hopefully. What we can experience is what we were talking about earlier, muscles like the piriformis muscle that goes from the front of the sacrum across to the greater trochanter. So it's wide end here, then narrows across. And so that muscle will laterally rotate the femur, it will abduct the leg in this position, hopefully. It's also got this close relationship with the nervous system, where the sciatic nerve goes through it, under it, over it, or whatever it does. So let's imagine for a moment that the client we're talking about here has been sitting for a long period of time, and this area in the hip has adapted to that lifestyle. So if you imagine when you're walking and you've got this gait action, so I think this is what you meant, Marina. So as the leg steps forwards, this side of the pelvis will rotate up and back. And then when the leg steps backwards, this side of the pelvis will rotate forwards and down. So that as you're walking, you're getting a lengthening and shortening of the legs almost as your hip rotates and the pelvis drops and rises, just the way the body works. So as QL lifts the hip, as the leg swings through and then drops, so you get this, and it's doing the opposite on the opposite side. So when the foot hits the floor and the foot lifts off the floor, you get this swing phase through the motion of walking. Now, what can happen is if these muscles, nerves get tethered, the muscles adapt, we've been sitting a lot, we're losing the pertness in our bottom, the function, clients complain about, you know, flat buttocks or whatever it is, or weak glutes, which is a whole other Q&A. That can influence, when we're walking, what might be happening. So let's just imagine for a moment that, let's just pretend that it's one side of the hip has adapted whilst the hip or the pelvis or the sacroiliac joint is in the position of leg forwards, pelvis rotated up and back. Let's say it's adapted at that point, it's got tight or overactive. If you imagine hanging that individual by the shoulders and the legs are swinging freely, if that side of the pelvis is rotated up in the back, the length of this leg is going to appear shorter than the other side, just because the point at which the pelvis is in. Maybe QL is a little bit tight over here as well, or in spasm, got a hinge going on. And so this has created a functional leg length discrepancy that can be remedied with exercise at this point, by mobilizing the nerve, muscle energy techniques on the muscles, joint mobilizations, stretching, whatever it is you follow as a system. If that happened when the leg was in the backward phase, pelvis was rotated forwards and down, the length of the leg would appear longer on that side. So you're getting this kind of lengthening and shortening. So the idea is that the pelvis, hopefully, when it's moving, gives this motion. This allows us to then be able to evaluate by testing comparisons between pelvis and leg length. We can start to identify if there is a discrepancy. What it doesn't tell us as manual tests is if it's structural or functional, and that's the bit we want to find out. So an X-ray is the most objective way to know if you have a structural difference. Structural leg length discrepancies are actually quite rare, where you're born with different length femurs. And I think it's anything, anybody who's out there who can correct me if I'm wrong on this, I'm not sure. I think it's only if it's over 11 millimeters is it classed as a clinical problem, or if they're super symptomatic. Which to me, that's huge. That might be where a clinical intervention using built-up shoes might happen. Surgery is extremely intrusive, so you know that would be a last port of call. But if someone's miserable, then obviously they want to address that. But most commonly, where we have this pelvic gait, I like that, Marina. I'm going to use that terminology now. Where you've got this functional appearance of a leg length discrepancy, it can help us benchmark and measure. And over time, if we can reduce that difference in where the malleolus, the medial malleolus meet, the medial malleolus is where, excuse me, Skelly, is this inside ankle bone. And if you understand how to do that benchmark where you can put them together and measure them, we can monitor over time. If that starts to reduce and they become level, we can surmise, if we're doing these pelvic function improvements, that actually it wasn't a structural leg length discrepancy, it was a functional one that was coming from higher up. And that's really common. It's not normal, it's common. So many people say, oh yeah, we've all got a leg length, yeah, we've all got a leg length discrepancy, it's really, everyone's got one. Well, okay, maybe. The question isn't, do I have a different length in my legs or a leg length discrepancy? Question is it functional or is it structural? If it's structural, you can't do anything about it, you're not symptomatic, don't worry about it. If you're symptomatic, go and see somebody if it's getting to the point where it's affecting your quality of life. If it's functional, I just want to run through a couple of ways the body can compensate, potentially give you problems or discomforts, maybe in your tibialis posterior area. So if you imagine that this is Charlie, and he's been sitting at his desk studying, typing away on Facebook in UK PTs maybe, and over time, this side of the pelvis, or either side, this side, let's say, has adapted and the muscles have gone, not using these muscles, the brain's saying, look, let's just make that muscle a bit more ligamentous, and it doesn't fully contract and relax in the same way. And it does that when the pelvis is rotated forwards and down. So that gives Charlie the appearance of a functionally long left leg, for example. Yeah, he doesn't know this has happened, he's fine, but he's going running because that's what Boris says he can do. So he's going out running. And what's happening is because that leg is appearing longer due to this problem with the pelvis, this dysfunction of the pelvis, that knee is buckling in more. Now, I'm exaggerating here. So biomechanical problems take a long time to show themselves. And so it can be a very minute little knee valgus, but if that's happening and he's out running and over time, those medial collateral ligaments become loaded, ACL, it's starting to grumble a little bit, and he says, I've got a sore knee. But the knee isn't the problem, or rather the knee is the problem, but the root cause could be up here. He might complain of shin pain, where the shin is kind of got a torsal rotation on it, or the foot is overpronating. And all of these can contribute to foot pain, shin pain, lower leg pain, knee pain, and yet the knee, the shin and the foot, they're not where it's coming from. It's coming from here, potentially. We've also got the nervous system in here where maybe Charlie's saying, I've got really tight hamstrings and I've been stretching them and they're just not going anywhere. But actually what's happened is piriformis and the sciatic nerve have got tethered. And so the hamstrings, when he does his deadlifts, the hamstrings are kind of hanging on. Oh, Charlie, I'd rather you damage a muscle than a nerve, and give him the appearance of tight hamstrings. But they're not tight. They're in a protection mode. They're trying to stop you from hurting your nerve that's tethered in here because the muscles in the hips are switched off, overactive, in spasm, whatever you want to call it, and affecting the pathway of the nervous system. Now, that's the descending adaptation or compensation. Let's go in the other direction. So let's say Charlie's adaptation, instead of being down into the knee and the knee being valgus, the same issue at the hips creates an ilium sitting higher on one side. So of course, Charlie isn't going to walk along tipping over to one side, or hopefully not. But what's happening here is that the QR muscle on that side is getting jammed up. The facet joints have got closer together, they've approximated, And so he starts to complain of back pain. But again, the back isn't actually the root cause of the back pain. It's coming from this compensation at the hips, potentially. There may even be a sort of diagonal link where you're getting a sore shoulder in terms of the way that the pelvis and the shoulder connect, and the body works in chains and sort of this zigzag fashion. And he's actually got a sore shoulder on the opposite side. But the shoulder isn't the root cause. It could be, again, the same issue at the pelvis, creating all sorts of sensations and alterations through the way the body functions and moves. Now, it all sounds quite dramatic, and it can be. For some, it affects their quality of life, and they're absolutely miserable. For some, they may eventually go on and need some kind of surgical intervention. What we're really interested in right here, and what I want to try and encourage you guys to do, is understand the way the body functions as an integrated system, how pain can have no relation to where you feel it, other than that's where it's talking to you. And we need to understand how to test the whole body to understand why Charlie is feeling a sensation in his calf, rather than assuming it is the tibialis posterior, because that's where it hurts. Because the body's really good at hiding and compensating and allowing us to get on with what we're asking it to do, even when there's underlying kind of intrinsic dysfunctions going on, because we're not using it in the way it's been designed. I hope that answered your question, Marina. Can you explain how the pelvic gait works? One knee flexes, something happens at the pelvis. I think that should, hopefully, I've answered that question. So I'm just going to come back over. Yes, no, I understand that, Charlie. But as you can see, when I get an example, it kind of spins off how I can help everybody listening to understand from a question specific. Obviously for you, you're passionate about your own symptoms, so I'm happy to do it. Yeah, no problem over there. Let's have a quick look over on Instagram. Oh, busy on Instagram. How are we doing over there, guys? Have a look. I hope you're eating your lunch whilst you're there. Done that one. Let's have a quick look. So bear with me. Sorry, guys. You're very welcome, Kamal. Okay, so we've got one more question. How are we doing for time? Ooh, I can go on a bit, can't I? Right, another really good question from Marina. So this is the last one for today. Can you explain a bit more about reciprocal inhibition? Can you explain a little bit more about reciprocal inhibition? So I've got an idea about what it means, but what I did was I used the tactics I was talking about at the beginning of this session of research. I thought, I'm going to go and do more research and see what comes up. So I went onto the internet and I had a look at some of my own personal resources. I save links and things when I find something interesting, and I knew I had one for the definition of reciprocal inhibition. Now, we can go from how we explain it to a client all the way through to in a lab with a degree level technical speak. But which ones are going to be most helpful? Probably the bottom half scope, certainly for me, because the other end is a little bit daunting. I'm not that level trained. So for me, and the way I want to share my understanding with you is, how can we help clients? Why do I need to understand this? And reciprocal inhibition is a really key component on the way I teach my methods in designing a strength training program, particularly for somebody who's maybe had this problem. So maybe Charlie Moe coming out of sitting for the period of lockdown and he's experiencing this problem down in his calf. I would use the law of reciprocal inhibition specifically to improve your function. So what I'm going to do first of all is just break down what I found out about the definitions of the two words. So reciprocal in the online dictionary, this is from a medical dictionary, and it's Latin reciprocus, which means based on back and forwards. So reciprocal, back and forwards. So something done in return. So if somebody buys you a Christmas present, you feel like you need to reciprocate. Yeah, so in those terms, there's a couple of ways we can look at it. What reciprocal means is it describes something that's the same on both sides. So that could be in relation to the human body, or if I was buying somebody a gift and they brought me one back, they reciprocated. So again, same on both sides. But also a definition I came across was the physiology of or relating to a neuromuscular phenomena in which the excitation of one group of muscles is accompanied by the inhibition of another. So that's tipping into the full definition. So I'll come back to that one afterwards. But reciprocal is basically the same on both sides. If you give, you take. So reciprocation is that forward and back. But if we add the word inhibition after it, it's going to just alter that meaning. So if we talk about what inhibition means, again, from the online dictionary, if we use Collins or Merriam-Webster, an inhibition is a force that prevents something from happening. An inhibitor stops something from happening. Where's the other bit? Here we go. Now this, so you think of the two words together. So reciprocal is where it's the same, both sides. So if we're talking about the body, same on both sides. Inhibition means stopping the same happening on both sides. So let's put the two words back together and then we'll put it into context. The law of reciprocal inhibition when it comes to the body is one of the first things you learn in your level 2 or level 3 anatomy and physiology training. So reciprocal inhibition is, in the simple terms, when an agonist contracts, it reciprocally inhibits the antagonist from contracting so that you get movement without injury. So when muscles work in pairs, is I think the language at level 2, I'm not sure we talk about reciprocal inhibition at level 2, that's certainly level 3, but muscles work in pairs. When the agonist contracts, through the law of reciprocal inhibition, the antagonist relaxes or lengthens to allow safe movement to happen without getting an injury. Because if this one contracts and this one's contracting, and that's something else. That's either isometric or something else. Isometric is where they both contract isostatically. That's something else altogether. So the law of reciprocal inhibition, now I found, this was one I found in my little portfolio of resources because I really like this definition, and it's taken from Massage Therapy Principles and Practices by Susan Salvo. And she defines the law of reciprocal inhibition as when the central nervous system sends a message to the agonist, the muscle that's causing the movement, to contract, the tension in the antagonist muscle, or the muscle opposite, is inhibited by the impulses from the motor neurons and thus must simultaneously relax. So again, I always like to use visuals. So when the agonist contracts, sends a message through the motor neurons to ask the antagonist to lengthen and relax. So what? We can take advantage of this when it comes to movement, understanding movement, and when a muscle is a problem. So again, coming back to the hips maybe, and I always like to use the hip flexors and extensors as an example. If a muscle is tight, overactive, subclinical spasm, dysfunctional, in a state of constant contraction, I want you to imagine for a moment how that's going to affect its antagonist. I'm going to say that again. So if a muscle, if an agonist, let's say a hip flexor, is problematic, tight, overactive, dysfunctional, in a constant contraction, how is that going to affect the law of reciprocal inhibition in relation to its antagonist? So using a hypothesis, because we don't know, by the way, nobody knows, this is all guessing and kind of putting information together, just as a comfort blanket for most of you guys. When an agonist is in a dysfunctional state, let's say the hip flexors, we don't use them, we're sitting, they're lax, they're, in a constant contraction because they're not being used properly. How does that law of reciprocal inhibition then affect how the glutes function, or the hip extensors, sorry, function? Because it's going to actually potentially be problematic in both sides. It's going to affect the agonist and antagonist, will affect each other if we are to believe and accept that they work in pairs, they influence each other. So rather than simply looking for the muscle that is the problem or the muscle that is problematic, we should also look to the antagonists. So again, it could come back to Charlie's question about tibialis posterior. We might look at the dorsiflexors, as you know, dorsiflexion, plantarflexion is my language. Sorry, Charlie, I like to simplify that. So that, sorry, Leah, is there a question there? Just if it's a question, no, right, okay. So that when we're thinking about the foot, for example, if you have a problem in your plantar flexors at the ankle, is that because the dorsiflexors are a problem, or vice versa? So we could, when we're writing strength training programs or movement-based programs, we could use that law of reciprocal inhibition to help somebody's movement quality based on taking advantage of that law by improving the function of the agonist. And we might use techniques like, I really like METs, so muscle energy techniques. So if you haven't already experienced or seen or heard me talk about the 2020 technique, which has been researched a couple of times, originally by Rebo Siskar et al., looked at post-contraction sensory discharge. We added numbers to that because that was a sub-maximal endurance hold. So we said 20 seconds, holding it at 20% effort. And the idea that this static 20% effort, 20-second hold of the agonist is a really safe, easy, low-grade technique to improve the function or the quality of the messaging from the brain to the muscle about how the muscle should work. If we then follow that with, put this one into place first, then immediately or in the same session or within a short period of time, do strength work on the antagonist strength work could, by the law of reciprocal inhibition, help the agonist function to improve. So it's this kind of playing around with working the agonists and antagonists when it comes to programming exercise. So we can often think about programming in terms of push and pull. We can think of it in terms of upper body, lower body. We might think of it in a variety of ways. I like to work from agonist and antagonist. I think that takes advantage of a natural law that we are hypothesizing happens within the human body. So I'm hoping that answers your question, Marina. I did have a little nerdy route around Brooke, the Brooke Bush Institute. I can never say his name. The Brooke Bush Institute. He's a great resource again, and he's done a little piece describing reciprocal inhibition, goes into a little bit more detail. He also talks about Susan Salvo in his piece on his website, which is where I got that other piece from as well. So she's obviously a good resource if other people I respect are, you know, they're advocating those individuals as well. So that brings me, I think, to, we've got 10 minutes and I've got another meeting at 1 o'clock, a really important one, about the safety net system that I was talking about earlier, where if you want to go through an online safety net system to understand signposting for your symptoms or for your clients, we can help you out. Really quick, really simple, no waiting around. There's physios, osteos all involved in that. And so what we can do is we can really help and guide very quickly without having to turn up for an appointment. So it's perfectly safe. So let me know, just get in touch. You can email me, rachel@biomechanics.com. I haven't had time for the books. We'll have to do that next time. So next week, movement analysis is going to play in. Charlie, I'm sure you got some information from today that'll go along with your question anyway. Hopefully that was helpful. So John, Jackie, Leah, Charlie, over on Zoom, thank you for being here. Instagram, hi Raoul, good to see you. So if you've missed this, guys, if you've just logged in, I'm going to upload it over onto the Biomechanics Education YouTube channel, which is where all of the past live Q&As, Biomechanics Q&As are stored. You can go and look back over the whole of last year if you're really interested. There's some really interesting topics that are discussed. And I'll carry on doing this whilst it's free because A, I enjoy it. B, I get asked loads of questions. C, they're usually helpful to a lot of people if we do this publicly. Number one, guys, do not be afraid to get it wrong. Please, ask away. Feel free to share your stuff. You're very welcome. I did, thanks, Charlie. Feel free to ask away, and remember, I will always happy to signpost. So, till next week, guys, have a great week, stay safe, and keep questions coming. See you next time. Just click off from Instagram and Zoom. See you guys.